Good evening, students. Today, in this small online class, we will be covering the acute alcohol intoxication, which is one of the presentations in the emergency department of various other alcohol related issues. So this is one of the topic in a very series of lecture. The other topics that will be deliberated subsequently will be acute alcohol withdrawal, neurological manifestations of alcohol use disorder, and alcoholic hepatitis. So what is ethanol? Ethanol is a water soluble alcohol. And how is ethanol absorbed in the body? Ethanol is absorbed mainly from stomach. 70% of the ethanol is absorbed from stomach, 25% from the duodenum, and the rest, whatever is left, will be absorbed in the distal part of the intestine. The peak level of alcohol are reached within 30 to 90 minutes just after ingestion. So whatever you do, once the alcohol has been ingested, it has to get absorbed in the system because the absorption rate is very fast, being it water soluble, and the peak levels are reached within 30 to 90 minutes. So how is alcohol metabolized in the body? Alcohol undergoes metabolism in the liver by enzyme known as alcohol dehydrogenase. Alcohol dehydrogenase is also located on the mucosa of the stomach, and that is where the exact metabolism of ethanol start taking place. But this gastric alcoholic dehydrogenase is somewhat deficient in the women population. The vulnerability of women is due to acute complications of alcohol is due to decreased first part metabolism in the first place because of lack of alcoholic dehydrogenase in the gastric mucosa and the small volume of distribution. So if you ask me, sir, what is the standard drink of ethanol? So ethanol, when you see a bottle, they will be mentioning various percentage. Suppose if you take a beer bottle, they will be mentioning somewhat around 4.5 to 5%. When you take a bottle of rum or a whiskey, it mentions around 40%. So this is alcohol by volume. That is, in 100 ml of alcohol, whatever is present, the volume that is in liters or milliliters, the volume of the alcohol is around 40%. So with that, the standardization of the density of alcohol is around 800 grams per liter. So when we talk about pure alcohol mass, it will be in volume of the drink in liters with alcohol by volume, then to be multiplied with the density of ethanol. So a standard drink is defined as whatever contains 14 grams of ethanol, like 350 ml of beer or 40 ml of rum or whiskey. So how do you define binge drinking? A binge drinking is defined as consumption of 5 standard alcoholic drink on a single occasion that results in acute alcohol intoxication. The next question is, what is serogenic doses of ethanol? Are the serogenic doses of ethanol same for men and women? Consumption of 60 to 80 grams per day for 10 years by men will be defined as serogenic, and 20 to 30 grams per day for 10 years by women will be considered serogenic. What is definition of acute alcohol intoxication? As per the Diagnostic and Statistical Manual of Mental Disorders 5, acute alcohol intoxication will be defined if any one of these 6 features is present just during or after ethanol ingestion. Those 6 features are slurred speech, incoordination, unsteady walking or movement, presence of nystagmus, attention or memory deficit impairment, and near consciousness or coma. This following chart gives you a rough level of blood alcohol levels with symptomology symptomatology. So you need not remember all this milligram per deciliter or symptomatology. What you need to know that firstly, till over here, the things are still in control. This will be considered from mild to moderate rate of impairment of either the social functions or the psychological functions. However, once the lethargy has set in, once the coma and has set in, these things become life threatening, and it is anything which is greater than 0.4% alcohol present in the body will be considered life threatening, that and will require hospitalization and immediate care. So as I told you, what does alcohol do in the body? This is a very important slide, and you have to pay a you have to pay some attention to understand this. In a normal person or a person of sobriety, you have to understand that the inhibitory effects of GABA is controlled with the excitatory effect of glutathione on NMDA receptors, where GABA AA receptors are here and NMDA receptors are here. This is absolutely balanced, and that is how a person is able to function. What happens with ethanol is basically a CNS depression. So it acts on the GABA receptors, and that is how the tilt shifts towards inhibition or sedation, and that is what happens in alcohol intoxication. So if a person keeps on consuming ethanol, what happens over a period of time is the GABA receptors gets down regulated. Hence, more and more ethanol will be required to achieve the same effect. And as far as the NMDA receptors are concerned, or the glutathione responsive receptors are concerned, they become more sensitive to glutathione, and the receptors also are upregulated. So that is how in a person with an alcohol use disorders, or the person who has been chronically abusing alcohol, the state of balance is achieved by down regulation of GABA and up regulation of glutathione receptors. So what happens in acute alcohol withdrawal is there is hyperexcitation because of number of glutathione receptors being increased and number of GABA receptors coming down. So for pushing of this GABA curve, what you require to do is you have to give the person a lot of benzodiazepines. So we will be talking about alcohol withdrawal in our next class. So how to establish a diagnosis of acute alcohol intoxication? The diagnosis of acute alcohol intoxication is basically a clinical one, and it is a diagnosis of exclusion, because the person in generally is brought by somebody else complaining that he presents to the emergency department with something very unrelated, like he will get into a fight, he will injure himself, falling down from staircase, meeting with a road traffic accident. So what acute alcohol intoxication does is it impairs the process of our diagnosis. So you have to be very careful when you are just trying to establish a diagnosis of only acute alcohol intoxication. And the history prior to that is sometimes available. The person may be smelling of alcohol, but at the same time you should also rule out other psychoactive drug abuse. And please do rule out head trauma, hypoxia, hypoglycemia, hypothermia and hepatic encephalopathy before you level a person just with acute alcohol intoxication. So how can a definitive diagnosis be achieved? Once the other diagnoses have been ruled out, what you need to do is you can achieve it with either a breath analyzer test or measuring absolute alcohol levels in the blood. So what all metabolic derangement can be expected in acute alcohol intoxication? These are the most important metabolic derangements that can occur in acute alcohol intoxication. One is presence of hypoglycemia, lactic acidosis. All are in hypokalemia, hypomagnesemia, hypocalcemia and hypophosphatemia. So how to manage in case of acute alcohol intoxication? As in any other poisoning, supportive care, prevention of absorption, giving antidote and increasing elimination. So in this acute alcohol intoxication, as it is a water soluble alcohol, it is neither very prudent because activated charcoal really does not help in prevention of any absorption, or there is no known antidote to be given for alcohol absorption, because it gets metabolized very fast. Even a normal person metabolizes around 30 to 20 grams of ethanol per hour, whereas in a person who is chronically into alcohol, use of alcohol, they metabolize around 30 to 40 grams per hour. So there is really no need for development of any antidote, because at the end of the day, this is going to be metabolized within next around 5 to 6 hours. So mild cases where there has been just some incoordination of gait, there is memory impairment, there is some amount of agitation, so they just may require some amount of sedation, which can be given by oral lorazepam. And if they are having nausea and vomiting, the control of emesis may be done by parenteral pantoprazole 40 milligrams IV and ondansetron 4 milligram IV. Now in moderate to severe cases, where there is lethargy, where there is confusion, where the person is agitation, who may cause harm to himself or to the others, so the following things should be done. First is look whether the airway is secured or not, whether the individual is able to maintain the airway. In case if he is not able to maintain the airway, please put in a good tube so that the tongue does not fall back. If you feel that the airway is not protected, gurgling like sound is come up, the gag reflex is impaired, please kindly protect the airway by intubating the patient. Secondly, the person should be made nil by mouth, because there is a propensity that the individual will vomit and will aspirate. You must have heard a lot of stories of people who had gone to marriages, they had consumed a good amount of ethanol, and then finally they drowned in their own vomitus. So in order to prevent such cases, please make the patient NPO and place him with IV hydration. Now, why do we have to place the person on IV hydration? Because alcohol is a good diuretic. So alcohol over a period of time will cause dehydration in the patient. So in case if you have to prevent the dehydration, please provide him with hydration. Ideally you should use non-dextrose fluid, but in case the person is having hypoglycemia, so you need to supplement the person with dextrose. But just remember one thing: if you are facing acute alcohol intoxication in a chronic ethanol abuser, his thymine levels in the will already have been depleted. So in case if you give dextrose, what will happen is there will be active metabolism of glucose in the brain, and by the use of transketolases, which requires thymine as a support, the whole thymine will be washed off, and you will predispose the patient to go into a Korsakoff syndrome or a Wernicke syndrome. So we'll be covering Wernicke syndrome and Korsakoff syndrome in the coming classes when we talk about the neurological manifestation of alcohol use disorders. But before you start correcting hypoglycemia, please supplement the patient with thymine. Give injection thymine 500 milligram, dissolve in 500 ml of normal saline over 30 minutes. At the same time, start correcting the hypoglycemia with 50 ml of 50% dextrose, and you should place the person on running 5% dextrose. If the person is agitated and violent, do apply physical restraint as per the institutional policies till the time the chemical restraint is already in place. So how do you chemically restrain such person? Use injection diazepam 5 to 10 milligram stat. You may repeat the dose within next 5 to 10 minutes to achieve a Richmond agitation sedation scale of -3. You may use injection lorazepam 4 milligram stat. You may repeat the dose after 15 to 20 minutes. And lorazepam will be the drug of choice if the person is already a known case of cirrhosis of liver. The other typical antipsychotics that can be used is injection haloperidol in combination with phenargan, promethazine in 5:25 milligram in combination. But always remember that the effect of the medications, such medications are additive in nature and may lead to respiratory depression. Hence, the team has to be prepared to tackle such emergencies in case the person is going into respiratory depression. If a person goes into respiratory depression, he is already intoxicated with ethanol. I don't think if you just bag and mask him for around 5 minutes, it is more than sufficient to bring him back. So meanwhile, when we are managing acute alcohol intoxication, do not forget the underlying disorder or the disease process, because we have presented to it, whether he has got into fight, fallen down from stairs, he has ended up in road traffic accident. Please conduct routine serial x-rays to rule out long bone fractures, NCCT head to rule out any EDH/SDH. Do a fast in the ED to rule out any hemothorax or hemoperitoneum. Simultaneously, urine drug screens are very available. Put 5 drops of urine in that, and you can see the number of lines that comes positive. If 2 of the lines are positive, it shows that the person has not abused. If a single line is positive, means the person has been taking that drug, whether it is cocaine, THC, opioids. So urine drug screens are now routinely used to screen the patient in the EDs. Now, role of ABG is only imperative if you find that the patient is breathing acidotically. So what you do is you do an ABG. A severe metabolic acidosis with a high anion gap always suggests a ethylene glycol poisoning. Along with alcohol, he must have been involved in obtaining alcohol from any illicit sources, very common in the dry states of the country. And that is how you have landed up with severe metabolic acidosis with high anion gap. And if you get some ketone body positive in the serum without any metabolic acidosis, that means he has abused rubbing alcohol or he has abused sanitizer. So 2-propyl alcohol. So those will require immediate different type of a care. They might require management of acidosis, they might require extracorporeal clearing of the toxins, CRRT. Just for the sake of knowledge, you may know ki metadoxin. Metadoxin, I have never seen and never used metadoxin, but as far as the books write, metadoxin is one of the drugs which can be used or accelerate clearing of ethanol in the bloodstream. With this, we have come to the end of the discussion today. In case if you have any doubts, you can definitely write it on the chat. And once we have done with that, do not forget to come back for the most important topic which we are going to cover next, that is acute alcohol withdrawal. I'll be waiting for the questions before I sign off for the day.